I'm going to give you a few tools about the how. As we go forward with the other sessions, you're going to learn more about the how and more in depth than I'm going to talk about today. We want you to get some bang for your buck today. And so hopefully you'll leave with some tools that you can start to practice. My name is Karen Jubanyick, and I am faculty in emergency medicine at the Yale University School of Medicine. I also trained in internal medicine. So the most important thing is that you really need to do this. You really need to believe in your heart that this is the right thing to do. And Dr. Ganaga gave us so many good reasons about the why, but you really have to believe it in your heart. And I'm going to tell you a story that really made me a believer. This is a true story, and it made me a believer and took that angst about, our patient's going to be mad at me for telling them the truth sometimes, by having these conversations. Sometimes we are the first ones when you have a conversation like this to tell somebody that they have a serious illness in a way that, at first they may struggle with. So this was a 38-year-old woman. She had metastatic breast cancer. She wasn't failing the treatment. The treatments were failing her. And she'd had increased spread of her cancer despite multiple lines of chemotherapy. So she goes to the onc clinic, and her usual relatively young faculty member who takes great care of her is away on vacation. And so she sees the head of the cancer center. And he's very experienced and came from another big system where palliative and hospice were very strong. And he tells the patient and her husband, who happens to be there, right now, I don't see anything that's going to change the outcome right now. This is very serious. I could offer you another chemo, but I think it's really going to make you sicker. Well, the patient didn't know what to say. The husband got angry. And many of us have seen that situation, right? Where the patient is just so stressed and often, just has this deer in the headlights look, and they don't know what to say. But family members sometimes can respond in different ways. And this family member was very angry. I'm never coming back here to see you. And, the head of the cancer center took that kind of hard. But he said about 4 months later, this was a few years ago, so people still wrote letters. He got a letter from the patient's husband thanking him profusely for being honest. And he said, we went home, we regrouped, and, we thought about how to make some meaning in the time we had left. And we went on some trips together. And he said, we went out and she bought gifts for each of her two daughters, who were 3 and 5 at the time, and wrote a letter to each girl for each birthday until they were 21. When I tell this story every time, I'm moved to tears, because by somebody actually telling the patient, that time is short in so many words, that gave the patient the agency to make decisions that if she had gotten the next round of chemo, the next type of chemo, and ended up in the ICU, may have lost that ability, right? If you're in the ICU on a ventilator, you are not able to write letters to each of your children for all their birthdays coming up. So I take this story around with me every day when I have conversations. And, every patient is different. You got to read the room, but, patients deserve to know the truth. And, you also have to believe that palliative care and hospice care is better care in many cases. Patients live longer. And as far as quality of life measures, they almost always live better. But in a lot of disease conditions, they actually live longer. So number 2, understand that goals of care conversations are a process, right? That starting the conversation in the emergency department may grease the wheels for conversations later in an illness or hospitalizations. The other thing is that, in the instance of somebody who has, say, a massive pulmonary embolus or something else that causes them to go into a PEA and then asystole when they're first found. They're given enough epinephrine, they get ROSC, and they're brought to the emergency department. But we often know what's going to happen, especially if the downtime was significant, right? And so, I make sure to tell the story that your family member died in the classroom or at home or wherever. And the paramedics or we were able to bring them back to life. But I make sure that in the story that I'm telling from the beginning, without taking away hope, helps them understand later when somebody tries to have the conversation in 3 days or 5 days that that this isn't coming out of nowhere and that they have some preparation for just how sick their family members were. Because think about it, where do most people get their information about the likely survival of a patient out of the hospital who has a cardiac arrest and found in asystole? We know that the survival, depending on comorbid conditions and age, may be well under 5% in that group, right? But lay people, they think the answer is closer to 75% because that's what they learn from watching TV. Somebody actually did the study where they watched a bunch of medical dramas and they looked at the cardiac arrests, and their survivability was well over 67%. And they published that in the New England Journal. So that's where the layperson's getting their information. So it is important to understand that you're just part of the process. And in the conversations that you have from that very first minute when you go in the family room and go talk to a family whose family member went into cardiac arrest, you may be able to, make the conversations easier down the line, depending on how you have that first conversation. Now, our own values as providers should never overshadow the true rationale for these conversations. And sometimes, and we're going to talk about a case next, there is a clear right answer of what should be done. There often is not, right? It's up to the patient's values and the family to interpret what those values would be. But sometimes there is a clear answer. And so here's a case. This is based on a true story, as all of my stories are. This is a 42-year-old woman. She had relapsed head and neck cancer. She went to an outside hospital with altered mental status, and she was found to have an intracranial hemorrhage. It was huge at the time. Her INR was 8 because she was already in DIC. And they transferred her to our hospital, and neurosurgery came to the bedside and said, look, this is impending herniation based on the CAT scan that was done a couple hours ago and the repeat one done when she got here, as well as her vital signs and her neurologic exam. NTD, nothing to do. NMO, not my organ. Those are things that consultants often say, right? And we've seen that. Interestingly, the patient is full code in the chart, and the patient's family corroborates this. Now, this was about 3 months ago when she first relapsed with her head and neck cancer. So this is not a recent discussion, relatively recent. And this patient's in your emergency department. Her heart rate has gone down to the 40s from the 90s when she first got there. Her blood pressure is starting to go down. Okay, so what do? Do you have to resuscitate that patient? And my tip number 3 is think like a surgeon. Okay, the surgeons have come by and they have said this is not a surgical problem. They cannot fix this. They are not offering to take this patient to the operating room. Just like, you've probably seen, a 96-year-old with dementia, with advanced coronary disease, already had 2 bypasses, now presents septic and in renal failure, and with evidence of a STEMI, right? The cardiologists are not going to take that patient to the cath lab in virtually all cases. Or if the patient needed a redo CABG, our CT surgeons are not going to take that patient to the OR. They're not going to offer that. And so this comes under what we would call non-beneficial care, what used to be called futile care. We try not to use futile because it depends what the goal is in terms of determining whether something's futile or not. But if the goal is to get the patient out of the hospital, to leave the hospital and go home, this patient that I was talking to you about, the 42-year-old with head and neck cancer who's herniating in front of you, that's futile, right? It's futile to perform CPR and give epinephrine if the goal is to get that patient home to be with family. It would also be considered non-beneficial care. And, many cases are going to fall in a gray zone. And I chose a case that from my memory was very black and white. And this really gets us to what emergency physicians identified in the past as the biggest ethical dilemma, was feeling like they had to resuscitate a patient for whom they thought it was non-beneficial to resuscitate the patient. And the answer is, there is nothing that mandates that you resuscitate such a patient. And, repeatedly being put in that position significantly contributes to a degree of moral injury, which can lead to burnout. And in addition, if you go and have the conversation again with the family, and in this case, it was a spouse and About 14 family members eventually gathered to the hospital by the time she started to get very sick and Brady down. And so she was already on the vent. She trached from her head and neck cancer. She was already on the vent, but she was starting to need a CPR. But by not offering resuscitation in these extreme cases, you often do a service in that you take the burden off of the family in making a decision. In this case, the family felt like the patient had said she wanted to be a full code. And I think that would be a big ask. If you're offering, patients have a reasonable expectation that if you're offering something, there must be a reason. And then we get mad and say, wow, we offered this resuscitation in this egregious case and the family wanted us to do it. Well, again, make sure that in these extreme cases that you think about whether you really do need to offer it. And the answer is you really don't. Everybody has their, there's going to be gray zones and everybody's going to have their own line. I use the example, we don't offer trips to the moon. We don't offer brain transplants. We don't offer antibiotics to patients with clearly the flu. We don't offer, aggressive 18-month courses of chemotherapy to the, typical patient who presents, or the oncologists don't, who presents with stage 1 breast cancer. They are given the choice between lumpectomy and mastectomy, and lumpectomy may be followed with a month of radiation and then 5 years of tamoxifen. But if a patient says, well, I'm really worried because 3 of my aunts 3 times removed had breast cancer, so I really want 18 months of the strongest chemo you got. That's not offered. The oncologist is not going to offer that to the patient. So I think that's important. 4, remember, your language is critical. What you say, and, also how you say it, but what you say matters. Okay. So how you say things, sit down. I'm not good about sitting down when I have conversations with patients, but when I have these types of conversations, I will always find a chair and I will always sit down. Patients and families, when given surveys after a conversation, even if it's not about something bad, and they ask, how long was the doctor in the room? If the doctor or provider actually sat down, they wildly overestimate how long the provider was in the room, and if compared to as if the provider stands. So sit down. Take courses on giving bad news. There's Vital Talks. That's actually, obviously a proprietary one. I don't have any disclosures to disclose related to that, but there are multiple other courses where you can go and you can learn techniques in addition to some subsequent episode from this series. Recognize this is a lifelong process on your part. And that's what's so interesting about this to me, is that I know I'm never going to be as good as I want about, doing this. I'm probably as good as I'll ever get intubating. Sure, maybe if I do 150 intubations this year, I might be better than last year, but realistically, that's not likely to happen. So I'm probably as good as I'm going to get doing intubations and putting in central lines. I am not anywhere near as good as I want to get in terms of having conversations. Every family dynamic is different. Reading the room, it's always different. So you can always get better. And that's, again, one of the really sustaining things about having an interest in this at this point in my career, is that there's always a goal, and I'm never going to get there. And in terms of learning how to do this better, bring in people. If you're a resident, you're going to bring in your attending, but ask for feedback. And learn even how to ask for feedback. If you're faculty, you can ask the residents and hope they tell you the truth. You can ask social work. You can ask the chaplains. One thing I used to do is, look for those nurses where you have a good relationship, but they're tough and they'll tell you. And that was how I got feedback early on. Just a couple quick things to practice in the next couple of weeks before we have our next sessions. I think it's really good to use warning shots and headlines when you're going to give bad news. I wish statements are really helpful. So you could say, I'm sorry that the news isn't good, or something like that. But a warning shot with an I wish statement, I wish I had better news. You're not saying I'm sorry, because there may not be any reason to be sorry specifically, not like a mistake wasn't made. And many people, if you use the word I'm sorry, many people are afraid that means you're apologizing for something, which you should do if you have made a mistake. But if you haven't made an error, you might not feel comfortable using the I'm sorry part. So I wish I had better news seems to go very well for me anyway, as a warning shot. Or I know this was not the news you were hoping for. And anytime you give a warning shot, you just pause. And then a headline is, I know you've been through a lot of chemotherapy and surgeries, but your cancer is back and it's spreading. That would be the example of a headline. So a warning shot first. I prefer warning shots and then a pause and then headlines. The other thing is, I actually don't use the P word, palliative, early in a conversation, especially in patients who are not already followed by palliative care, because many lay people think palliative care is hospice, that they're the same things. And you're going to get patients shutting down if you use the P word right away. So I often start the conversation saying, I know you're suffering. Most patients wouldn't come to the emergency department if there wasn't some degree of suffering. It's nausea, it's vomiting, it's pain, it's dyspnea, existential crises, agitation, all kinds of things. So I say, I know you or your loved one is really suffering. We have a team, and I say, your oncologist is awesome. They have to know all the different kinds of chemotherapies. They have to know lung cancer and colon cancer, et cetera. But there's another group of providers, a whole multidisciplinary team, and all they do is symptom management. And so it seems like they could be an important part of your team now, given all the suffering. And I've never had a patient or family say, no, I don't think I need symptom management when I brought it up to somebody with serious illness who's come to the ED with suffering. That is an emergency. And then I say, I'm honest with them. And once we get buy-in about the symptom management team coming, I say, look, they are called the palliative care team. Their jackets are going to say palliative care team, but that's not hospice. And I say that palliative care may be appropriate for those people relatively early in an illness for which they entirely expect to recover. So I use the example of, somebody with stage 2 breast cancer, very high expectations of survival. They may have unmanaged symptoms as part of the illness or as part of the treatment. And I tend to use that example and emphasize that example for somebody who's earlier in the course of the disease. And then I'll say, and then there are people, palliative care may have conversations about hospice, but tends to be at the very end of the illness. And that might be somebody with, pancreatic cancer that's spread. As far as communication tools, you'll learn from in future episodes about spikes, which is giving bad news, and remap. And remap is sort of sometimes associated after you give bad news about an illness, but is used when things are different now. And that's often how we start a conversation using the remap tools. And you can certainly Google spikes and remap and practice using spikes when giving bad news, whatever elements are important for you. I think emotion is where many of us feel like we can get better at giving time for the patient and family to, express emotion. And emotion happens to be one of the things in common in the spikes mnemonic as well as remap. And again, remap is good when things are different now. You had a patient with lung cancer and they were getting treatment, and now you have a patient who had a seizure with lung cancer, and now they're found to have metastatic disease to the brain. So my fifth recommendation is have a system in place for patient selection. So ideal screening system qualities for emergency departments is that they uses information that an ED provider will have hopefully relatively early in the visit. You don't want to base these systems on the change of creatinine from, over the first 48 hours of admission, right? Because that's not something the ED provider will have. Combining comorbid conditions. And so, a patient that gets colon cancer at age 42, you can expect their needs may be very different than a patient that is, well into their 80s with dementia, COPD, and stage renal failure. So the ideal selection system takes into account the comorbid conditions. Functional components are important, ideally, in terms of their ADLs and what the patients are actually doing. Maybe not today, but maybe last week, use a time course that may not reflect, active sepsis that's present today, but that's reflective of what was going on last week. And then some clinician judgment is always good. Talking about the ED screening modalities, the surprise question, Dr. Ganaga mentioned that, but a surprise question. So would you be surprised if the patient died during this admission? Or would you be surprised if the patient died in 3 months, 6 months, a year? One of the advantages of the surprise question is you can change the duration for providers. A disadvantage of this method is that a no is a positive screen. And so sometimes people kind of get turned around because no, I would not be surprised is actually positive, which means you actually might want to consider them for palliative or hospice and consultation. Clinician experience is a bit weighs into it a lot. There's the palliative performance scale. It's very functionally based. And so it may not be appropriate for people with longstanding disabilities, for example. There's the PCARES, which you can Google, and that was developed specifically for emergency medicine. And then people have homegrown EMR screening tools, which will alert, and a pop-up may come up. The advantage, it's automatic. Nobody has to think. The disadvantages tends to fire more often than you'd like. And in our experience at our hospital, when a palliative care fellow helped devise one, and she was EM trained, it made the clinician so angry that she had to take it down. To show you what the tools look like. So a quick summary. So one, I want you to really believe that it's the right thing to do in many cases, and that we're talking about with serious illness, to offer palliative care or hospice. Understand your conversation may only be part of the process and things will change the next day. Think like a surgeon. If you really believe that something is not beneficial, you don't have to offer it. That will protect you from moral injury, and it will protect the patients and may protect the family members from believing that, they killed grandma, when that's not the case at all. Your language is critical, so pay attention, get some skills, and you'll never be as good as you want. And use a system, ideally with staff buy-in, to help you develop whatever system you're going to use to identify patients. Thank you.